Okay, good morning again, everyone. Are we all awake? Everybody's had enough coffee, right? Okay. And you're all full of those terrific crab cakes, and you had a great dinner last night, and a good sleep, and my loud printed jacket is going to keep your eyes open. That's why I wore it today, because you're unfortunately stuck with me for an hour this morning, and I won't even tell you how long this afternoon. But I'll try to at least make this information entertaining so that it will stick with you. This morning, my task is to talk about the covariates that will affect the percentage of patients with pressure ulcers that are new or are worsened. So that we're going to have that conversation today. Our objectives for this morning are to demonstrate a working knowledge of three specific M questions. 1028, the active diagnoses, comorbidities, and co-existing conditions. 1060, height and weight. And 1620, bowel incontinence and frequency. We're going to be able to describe the intent. What is the reason behind 1028, 1060, and 1620? We will be comfortable interpreting the response options for 1028, 1060, and 1620. Using that knowledge, you will be able to imply the instructions to accurately respond to our practice scenarios. And then we'll discuss how we're going to identify and resolve the common stumbling blocks that will enable, so that everyone will be able to code these answers correctly. Just as we said yesterday, there are a variety of acronyms in this presentation. As I said yesterday, for those of us in this room who are not newbies, we're not new to home care, we toss these acronyms around on a regular basis. But there are people in your office, in your staff, whether they're new to home care, whether they just haven't perhaps heard that particular abbreviation. They're new to them. So please be sensitive to that. And be sure that when you use these acronyms, as we use them this morning, that your staff are equally comfortable with these specific definitions, so that they are not only using them, but they are also understanding them correctly. So take a look at them as we go through. The ASAP, Assessment, Submission, and Processing, BMI, CMS, we all know, diabetes, DM, discharge, follow-up, the OASIS form, HHA for Home Health Agency, and so on. You want to be sure that you're comfortable with these, that you know the difference between keys and QTSO. Throughout these 2 days, we have used the term code or coding. When we use it during this training, we are referring to the action of responding to or coding or scoring the OASIS assessment items. We don't want you to confuse that with the act of applying an ICD-10 code to a diagnosis. I know when I first started preparing to do this class back in the summer last year, I kept tripping over that. I kept saying, why do I have to say coding? I'm not coding. I don't do coding. It's too complicated. But that is the verb that we are using. That's the way we're using it, so please don't get confused by that. I want to have a little flashback to yesterday. What is a covariate? If you remember yesterday, we talked about the three different factors, the three different types of risk adjustment, and we defined a covariate. A covariate is a factor that affects the risk level for your patient to develop a new pressure ulcer or to have an existing one exacerbated or made worse. These four items are the risk adjustment covariates that affect the percentage of residents or patients with pressure ulcers that are new or worsened This quality measure is directly impacted by these 4 factors. M1028, active diagnoses, comorbidities, and coexisting conditions. That's the one we're going to talk about first. 1060, height and weight, is the one we will speak to next. 1620, bowel incontinence frequency, is not new, but it's used as a covariate, and we're going to talk about why and how. And last, GG, 17OC, lying to sitting on the side of the bed. Anne is going to go through that one very carefully and in detail, because this is a critical factor. So as I said, 1028 and 1060 are new to the OASIS-C2 as of January 1st of 2017. You can see these two on your slide. The active diagnoses, comorbidities, and coexisting conditions. This is done at the time points of SOC and ROC. 1060, height and weight, is also done at SOC and ROC. These are not done at recertification. When we look at 1628, bowel incontinence frequency, this item is done at SOC, ROC, follow-up, and discharge, but only discharge not to an inpatient facility. Okay, so you want to make sure that you are doing this correctly and only at the assigned time points. Let's take a look at 1028 in a little more detail. This is how the item appears on your screen or on your paper form. It reads as active diagnoses, comorbidities, and coexisting conditions. Check all that apply. See your guidance manual for a complete list of the relevant ICD-10 codes. Item number 1 says peripheral vascular disease, PVD, or peripheral arterial disease, PAD. Item 2 says diabetes. The intention here is that you should be identifying whether these diagnoses are present and active. That's a very important distinction that you need to be making. These diagnoses are very particular in that they influence a patient's functional outcomes and they increase their risk for developing a new pressure ulcer or having an existing one clearly become worse. Note that although the slide says 2 specific diagnoses, there are actually 3, because in the first box you have PVD and PAD, and in the second you have diabetes. We know that these disease processes can have a significant adverse effect on a person's health status and their quality of life. We need to know if these diagnoses are active and are they associated with the home health episode of care. Do they have an impact on the plan that your nurse is developing for this patient? We do this, as I said, at SOC, at ROC, but not at recertification or transfer discharge. Your process begins with identifying whether or not the diagnosis is present. And that's actually more complicated than it sounds at times. And we'll talk a little bit more about why that is. Your second step is going to be to determine whether or not it's active. As I said, active means, does it relate to the current plan of care? How would you go about identifying the diagnosis? Let's think a little bit about the referral when you receive it. What is it that you have in your hand? The referral came to you from a number of different sources. Let's say it came from a rehab or long-term care facility, a skilled nursing facility. What did they send you? You got an electronic referral, An electronic referral document has diagnoses listed, meds, activity levels, perhaps a paragraph of a summary. If it came from a long-term care or rehab facility, it's going to have summaries from all the different disciplines that saw that person. If they came to that facility from an acute care hospital, you should always be asking for that discharge summary as well. And you want more than just the simple summary. You want the course of care documents, because that will give you everything you need to know. So you can look through those documents to see what was written in that record, in that referral document package, by any of the physicians who saw that patient. Nurse practitioners, physician assistants, clinicians, nurses, therapists. You may have in your state, because there are many states represented here, you may have other levels of licensed personnel who are allowed to add information into that document. So you need to know, according to your state regulations, who's allowed to write information in there. And you need to scan through that and identify all the diagnoses that are listed. First, find them. Then we'll look at whether or not they're active and impacting your plan of care. What if the referral came from the community, from a physician's office or a family member? Now you don't have all these lovely documents to look at. Where are you going to get your diagnoses? Physician offices are required to be up on an EMR. Ask for the last 2 office visits and possibly a clinical summary if they have a summary document in the file. It will give you all the history documents, all the historical diagnoses, and it will tell you what the physician has been focusing on in the last 2 visits. And you'll be able to read it, if it's electronic anyway. So these are the different sources that we've just been talking about. All those transfer documents, progress notes, H&Ps, discharge summaries, med sheets, all the consults. That's why you're asking for the course of care summary. It's all those consults that were made that are going to give you clues as to what other diagnoses are lurking in the bushes. It's critical information that you really need. And lastly, when you go out and do the admission assessment, your assessment itself may indicate symptoms that are associated with one of the listed conditions, but the documented diagnosis may not be spelled out in the available records that you have. If that's the case, clinicians should contact the physician immediately so that they can ask for confirmation that the patient has that diagnosis. Once it's been identified, then you can move on to determine if it's active and related to the plan of care. When we talk about asking the physician to confirm it, a perfect example is the patient that's on a no added sweets or no concentrated sweets diet. That's what comes from the referral source. Does not say that they're a diabetic of any kind. There's no insulin, no hypoglycemics on the med profile. No concentrated sweets is the diet. So in the assessment, your nurse, who obviously knows how to do an excellent history conversation, is asking, so why is it that mom doesn't eat, candy, or she's supposed to stay away from a lot of sugar? Well, a long time ago they told her she might be a diabetic. And of course, at that point, mom pops right up and says, I'm not. Am not. I should know, that's exactly what my mother did. When she came off the insulin, as far as she was concerned, she was cured. That was the end of that. Not a diabetic anymore. Thank you very much. She paid no attention to the fact that we monitored and kept her on a no concentrated sweets, very careful diet. But she told everybody that would listen she was cured, and she was not a diabetic, and she most certainly was. But you can take that history and then have your clinician contact the physician office, send an interim order over. Please confirm diagnosis of. And you put in the diagnosis, and then you want to be sure whether or not they are actively treating it. You can put down a second question. Is this an active treatment diagnosis? Let them answer the question, put their John Hancock on the interim order, and now you have in your file the confirmation in writing you need in order to answer this question correctly. So now you have obtained the documentation that's defined here. You have the information, the past history, you've talked to the family, you've sent the order out to the physician in order to validate that this is a diagnosis that is present and it is or is not an active part. Anything you get verbally, you should always be sending an interim order to have written confirmation. You need a signature on a piece of paper in order to use that and to answer the question. So now I have this diagnosis. I got a signature on an interim order. Now what? How do I know if it's active or just historical? An active diagnosis is one that has a direct relationship to the patient's current functional, cognitive, mood, or behavior status. It relates to treatments or orders for the nurse that she is currently monitoring or assessing. It may be a factor in the risk of death or change in condition at the time of your assessment. If the condition has been completely resolved and there is no assessment, monitoring of any kind going on during your nurse's plan of care, then you would say it's inactive or resolved. But tread carefully there and look closely at the orders and the assessment plan that your nurse has created. Because if it's relating to it, you need to be sure that you are documenting it correctly. And again, you're going to look at all those same documents. What is it that the physician, the PA, the nurse practitioner is referring this patient to you to do? If the family's saying, well, she's always followed that no concentrated sweets diet, and they used to say she was a diabetic, but they don't say that anymore. They just say for her to follow the diet. Well, sure, they don't say that because mom didn't like it and she was fighting them. But if they don't discuss it and they just have her follow the diet, she behaves better. So they don't use the word. Makes a big difference. But you need to be sure. If you're checking blood sugars, if you're interviewing for symptomology, for low blood sugar events, then you are assessing for diabetes. And that's an active diagnosis. And if it's an active diagnosis, it's going to exacerbate the risk of a developing pressure ulcer or an exacerbating pressure ulcer. So that's the reason for looking very carefully at what you are documenting when you answer this question. Is the diagnosis active? If there is any form of assessment going on, any potential impact, then absolutely it is an active diagnosis. So here's a question for you. We have that lovely 5-day window to get the assessment done, right? It's not always easy to call the physician's office and get an answer back, is it? Wouldn't life be wonderful if they actually came to the phone, or if they responded to you within the 2 or 3 days you have left of the 5? What if information to define whether that diagnosis is in fact active or resolved is learned after the assessment completed date? Now what do? The OASIS data set should not be revised to reflect the new information. If your assessment completed date is entered in, come and gone, done. You cannot go back and open that document and change it at that point in time. The OASIS data set that you completed for SOC-ROC within the required time frame should reflect what was known and documented at the time of the assessment. But what if you discover that a documented active diagnosis was not on there and it does exist and it is creating an impact? What are you going to do? The data set is revised in accordance with the instructions in the memo number 1518, Outcome and Assessment Information Set Transition, ASAP, and the OASIS Correction Policy. You need to go there, read the instructions, and follow them so that the information can get into the system, but you are doing it correctly according to the rules. So let's take a look at the question itself, now that we've looked at all the background factors that might influence how you're going to answer it. You would select box number 1, peripheral vascular disease, PVD, or peripheral arterial disease, PAD, if you have determined that the patient has an active diagnosis of PVD or PAD. You would check off box number 1. That diagnosis, those diagnoses, are indicated by any of the following codes that start with those first 4 characters. There's a completed list in your manual. PVD or PAD is indicated by the diagnosis code that may start with the first 3 characters of 173, other peripheral vascular disease. For box number 2, diabetes, you would select this if they have an active diagnosis of diabetes. That uses codes that begin with E0 and then 9 through 13. It also does include the combination codes. If the assessment is completed and it's determined that the patient does not have a diagnosis of PVD, PAD, or diabetes, you leave both boxes unchecked. So now you have a pickle, don't you? You're out there, you're supervisors, quality managers, you're reviewing charts. You're reviewing OASIS documentation before your OASIS submission is locked and loaded and submitted. 2 boxes are not checked. Did the nurse just miss that question? Did she forget to answer it? Did she answer it correctly? None of these diagnoses apply. It's the responsibility of the agency, your responsibility, to develop an auditing strategy to ensure that this item is completed correctly based on the data that you have obtained. You need to find a process so that when you review and you find it like this, you are positive that the intent was correct and the information is correct and both boxes should not be checked. The dash value is a valid response for this item. I don't want you to be confused between leaving the boxes blank and using the dash. The dash value indicates that no information is available or it could not be assessed. You most often use this when the patient is unexpectedly transferred, discharged, or dies before the assessment of the item could be completed. Obviously, CMS expects this to be a rare occurrence. We have, for start of care, the 5-day window. For resumption, you have a shorter window. You would use the dash if you had not gotten any confirmation back from the physician, but you had to transfer the patient back to the hospital suddenly. They had an unexpected MI during the night and died on day 3. You hadn't received the phone call back. You don't know if the diagnosis is in fact active. It hasn't been confirmed as present. So you're going to enter the dash and then submit your OASIS. Those are the circumstances when you would use it correctly. But again, as I said before, creating an auditing strategy so that you know whether or not this is in fact, there is no active diagnosis, or, oops, forgot to answer that question. You need to be able to determine that. And the auditing strategy itself, that's process, and that is our responsibility as providers. It is not the responsibility of CMS to tell you how to go about doing that. As I said before, you have to have specific documentation in the record by a physician, a nurse practitioner, a PA, a licensed person who has it within their scope of practice according to your state regulations, that they are allowed to confirm the presence of the disease and whether or not it is currently considered an active diagnosis. You only look at the documented active diagnoses to answer this question. You cannot infer it based on your own technical knowledge without getting the written confirmation from an appropriate person and entering it into the record. In other words, you cannot check off diabetes because the patient and the family member tells you that mom is always drinking water, always running to the bathroom. Sometimes she smells like she's been eating honey for lunch. Yeah, that does sound like a diabetic. In trouble, too. But you can't do that. You cannot check off that box because that's not within your purview. You don't diagnose. So you would need to get it confirmed in writing by an appropriately licensed person. Okay, enough said. Let's play. Time to practice our scenarios. Who's got the clickers on these tables? Got it in your hand? Let's take a look at our first scenario. Okay. In our first scenario, our patient, Mr. J, has been admitted to home care services after surgery for a left total knee replacement. I hope his went better than mine. His medical record documents current active diagnoses of asthma and arthritis. The admitting clinician completes M1028 active diagnoses as noted below. Okay, look at your slide. There's nothing checked there. The clinician completed M1028 with a valid coding response. Do you agree? Is that true or false? Look at that. Aren't we all smart? That's true. And why? You leave M1028 unchecked if the patient does not have any of the listed diagnoses. Let's talk to Mr. B. Mr. B has type 2 diabetes. He takes metformin and glyphosate every day. His regimen includes regular blood glucose monitoring, exercise, and a diabetic diet. The physician progress note that you received documents an active diagnosis of both diabetes with peripheral neuropathy and peripheral vascular disease, or PVD. How would you respond to M1028? Will you check off box number 1? Will you check box number 2? Will you check both of them? 1, PVD, PAD, and 2, diabetes. Or will you enter a dash? Put down your answer on your clicker, and we'll see how we do. I'm checking to see if you're awake, if I've put you to sleep yet. In which case, we might have to stop for coffee early. And there we go, 100%. And the correct answer is to check both. Because, based on the physician's progress note, it clearly documents that this patient has diabetes with peripheral neuropathy and PVD. The patient has an active treatment regimen that includes specific tasks related to treating his diabetes. And for that reason, your 1028 should look like that at the bottom with both boxes checked. Let's try a different one. Mrs. K underwent a below-the-knee amputation due to gangrene associated with PVD. She requires dressing changes to the stump and monitoring for wound healing. In addition, peripheral pulse monitoring is ordered. The nurse practitioner's progress note documents the PVD and the left BKA. So how would you respond to 1028 this time? Will you check off number 1, PVD, PAD? Diabetes, number 2? Would you check both? Or would you put a dash? If you got your clickers, pick one of those. These are easy this morning. You've all been paying attention. You must have been reading your slides last night. Look at that. 100% on the correct answer. You guys are really good today. Okay, this would be correct. The PVD, PAD would be an active diagnosis because the nurse practitioner's note documents the diagnosis, includes as part of the treatment plan the peripheral pulse monitoring, the below-the-knee amputation dressing changes, and wound status monitoring. So those are all related to the diagnosis, making it present and active. Okay, let's move on to 1060. It gets a little warm up here. Okay, height and weight. Well, first of all, this is a touchy little subject, right? The majority of your patients tend to be women, and who's got the guts to sit down with another woman and say, so tell me, how much do you weigh? Think you're going to get an honest answer to that one? Don't be asking me. This is what your box looks like. Height and weight. It clearly tells you, while measuring, if the number is between 0.1 and 0.4, that you need to round down. Between 0.5 and 0.9, you round up. This is known as mathematical rounding. It's an understood rule. Height and weight are here, and there are no decimal points between the boxes. They are giving you some direction in terms of the weight, and I want you to read that carefully because there's language in here that has been confusing, and we're going to go through the wording itself very carefully to be sure that we can eliminate as much confusion as possible. It says the base weight on the most recent measure in the last 30 days. Measure the weight consistently according to standard agency practice. For example, in the AM after voiding, before meals, with shoes off, etc. There's a lot of information in that sentence, isn't there? What is the intent behind collecting this new information, trying to pry out of your patient their height and weight? This supports the calculation of the patient's body mass index, their BMI, and that BMI is a direct influencing factor on their risk for pressure ulcers. We know. We've seen enough home care patients. We've seen enough patients in hospitals and nursing homes. We know what the BMI is going to do to their risk for developing a pressure area. We know that if there's a large amount of body mass pressing on a joint area, a bony prominence, and the person's not being turned, they're not moving around, they're going to break down. This is a very high risk factor. And so that's why it is one of the covariates determining the patient's risk for developing a pressure ulcer. It also is going to impact your nurse's plan of care for nutrition and hydration so that you can keep the weight stable and improve the BMI to its optimum point. Weight measurement is also a very consistent common parameter for monitoring and controlling heart failure. We complete this item at SOC and ROC. Let's talk about the assessment process, the how that you're going to use to get the actual height of your patient. The guidance says, measure height in accordance with the agency's policies and procedures, which should reflect current standards of practice. Measure and record the height in inches, whole numbers, and when you are reporting the height for a patient with a bilateral lower extremity amputation, measure and record the current height after the bilateral amputation. And you would use the longer of the two extremities because it's rare for them to be identical in length. Let's look at that first sentence again. In accordance with agency policy and procedure. So you have a policy and a procedure back home in the office, in your procedure manual, for how you want to get to this person's actual height and actual weight. Consider how you will answer the question when someone comes to you and says, and what is your validated source for that policy and for that process? What are you basing that on? It is not going to be acceptable to say, well, that's what I think we should be doing, because you're not necessarily a validated resource, are you? You need to have some kind of a validated technical resource that you are using for your process for obtaining this height. You're going to complete this particular assessment only if MU100 equals 1, start of care, or 3, resumption. You record the height to the nearest whole inch using mathematical rounding and entering the numbers you obtain in those boxes just as it's shown right there. Weights should be measured in accordance with the policy and procedure, which should reflect current standards of practice. Again, what is your validated resource? Are you using the VNAA procedure manual? Are you using Robin Rice? Are you using some other particular research manual? You need to have a validated resource that you are citing as the footnote in your policy. Measure and record the patient's weight in pounds. And understand if the patient cannot be weighed because of extreme pain, immobility, the risk of pathological fracture, then you may use the dash value and document the rationale in the medical record. You cannot do one without the other. If you use the dash, then your nurse's admission assessment narrative for the SOC or ROC must have a valid reason noted. The patient has a very high risk of pathological fracture secondary to. The patient suffers from extreme pain from this diagnosis, AEB, as evidenced by whatever. You need to have that sentence in there. You're going to complete this again if your M100 equals start of care or resumption of care 1 or 3, using mathematical rounding, whole numbers, and entering them in this box as is shown on this slide. Again, the dash value is valid, but only when no information's available and you are unable to assess this item because the patient has been, again, unexpectedly transferred, discharged, or died before you could actually do this. As always, in all of the items we talk about today, the dash is expected to be a very rare occurrence. So let's take a look at a couple of practice scenarios. Mrs. G has congestive heart failure and advanced osteoporosis. She is at risk for pathological fractures. She is pain-free at rest, but experiences severe pain when she moves. Daily weights have been discontinued as part of her prescribed medical care due to pain management. So how will you respond to 1060B, the question of this patient's weight? Will you enter a dash here, or will you leave this blank? Use your clickers, select A or B, and we'll see how we did. All done, everybody? Make sure you click either A or B. Very good. 100% said they were going to enter a dash here, and you're all correct. And the reason being, she cannot be weighed because of the extreme pain caused by motion, the high risk of pathological fractures. So therefore, you're using the default response correctly. Let's try again. As part of the start of care comprehensive assessment, your nurse needs to obtain a weight for Mr. B. Mr. B has had bilateral lower extremity amputations due to complications from diabetes. His legs are now uneven in length. Using a tape measure, the RN measures the patient's current height while the patient is lying in bed. She obtains two measurements, 64.4 inches and 60.8 inches. As we said, it's very rare for the two remaining to be identical or even close. How would you respond to 1060A, the height question? Take your clicker, select a number, 61, 64, 65, or a dash. What do you think is the correct answer for Mr. B's remaining height? Remember to round according to the mathematical rounding principles. And we have a little bit of a spread now. Let's see what happened. The correct answer is 64. Because you use mathematical rounding and you use the longer limb. The rationale is that when you are reporting height for a patient with the bilateral lower amputations, you measure the current height, the residual after the amputations. Because they are uneven, you have to go with the longer limb. And the mathematical rounding brings it to the nearest whole number. Okay, last scenario. During the start of care home visit, the nurse completes the assessment. The agency's policy says the patient's weight is to be obtained with footwear removed. The nurse assists the patient to remove his shoes and obtains his weight. The weight is recorded as 126.8. How would you respond to 1060B? A dash, 126, 127, or 130? Select your number, and I have 100% on 127, which is correct because we rounded to 127 and the nurse removed the shoes to be in compliance with the agency's policy. Which brings us back again to what is your validated resource for your policy and how you are going about doing this. I want to move to that 30-day piece of the assessment question because there's been a great deal of confusion about it. On day 20 of a home health episode, Mr. Y is transferred to acute care and is hospitalized for 3 days. On day 24, his services resume. During the resumption assessment, the clinician attempts to weigh Mr. Y, but he's unable to stand on the scale due to shortness of breath. The clinician locates the following information. From the most recent start of care assessment, 24 days ago, Mr. Y has a documented weight of 175. The weight was obtained by a different clinician from the same agency. The hospital medical records from his recent admission indicates his most recent weight to be 177. So now, what weight are you going to use? Bearing in mind how the question was framed when you were asked. Is his weight 175? 177? Do we use a dash because he couldn't stand on the scale and leave, or do we leave it blank? Select a number, and we will see how you are interpreting the 30-day window. Is it 175 or 177? Is it a dash or is it blank? I see some conversations going on this time. This one's not so easy, is it? And look at that. Okay, we have a pretty even split here, don't we? Okay, let's talk about what the correct answer actually is. The correct answer is 175. Okay? Now, we need to understand the why so that you can be sure that when you go back to your agencies that you are training your staff properly and actually getting the correct information. You would enter the weight as 175. This patient is unable to be weighed on day 24 due to shortness of breath. In this instance, we can use a previously documented weight for the following reasons. The weight was obtained by the same agency on the start of care. The weight was obtained within the 30-day window because the resumption of care occurred on day 24. What you cannot do is use a weight that was obtained in the hospital. What you cannot do when you go out to the house to do a start of care, holding the physician office weight in your hand that was done within the last 30 days, you cannot use that weight. You need to do the assessment according to your validated resource on your policy. You do the assessment. If the patient symptomatically cannot be weighed, you cannot use that weight because it was not obtained by your agency within the preceding 30 days. It doesn't have to be the same clinician, but it has to have been obtained by your agency. And this height and weight issue, predominantly the weight question, does bring up a significant number of questions for providers. Am I buying every clinician a scale? Am I buying scales just for my admission team? Am I buying them only for the cardiac rehab nurse? Do I buy every patient who doesn't have one a scale? How do I know his scale is accurate? These are all valid concerns, but you need, again, go back to your validated resource for how you write your policy. Make sure that you have very clear guidelines for yourselves, and then operate within them. But know that the information you use to answer the question must be gathered by you. You cannot use data from an other source, from a hospital, a long-term care, a rehab, a physician office, even if it's within the 30-day window. So it has been a source of confusion. For a while, people were thinking that they could use data from that referral source because it was within the 30 days. But we all know, when you're assessing congestive failure especially, it's the actual number itself is less critical than the difference between the weight 2 days ago and the weight today. And if the weight 2 days ago was on a different scale that's calibrated differently and is obtained differently, perhaps on a seat scale as opposed to you making the patient stand up, it's not going to be the same. It's not going to be a valid reference. And that's why this question and its rules are set up the way they are. Okay, that brings us to 1620. This is such a lovely topic for this time of morning. I apologize. Okay, bowel incontinence frequency. This is not a new question that we're asking, but it certainly is as delicate a question to approach with your patients as asking them what their weigh is. When your nurses are taking a health history as part of their assessment, they need to be asking these questions. In my spare time, I have a short attention span, so I like to do a lot of different things. I have done some teaching with nursing students. One of my favorite occupations with the first clinical experience is to pair them off with another student they don't know at all. I make them draw names out of a hat. You should try this in a staff meeting. Put every clinician's name in a hat. Make them draw the names so they're not partnering up with their best friend. Then have them take a thorough health history on this other person and actually write it up. See how they answer the questions. See if they actually ask the questions. It can be a very entertaining exercise, and you will learn a great deal about what your staff can and cannot do in taking an appropriate, complete health history. And I can almost guarantee you, they're going to skip right on over this question when they're talking to their peers. And they shouldn't be. You need to know, how often does this patient experience bowel incontinence, and to what degree? It refers to the frequency of the symptom, not to the etiology or cause. It's not addressing treatment of incontinence or constipation, i.e., the development of a bowel regimen. We do this assessment at SOC, ROC, follow-up, and discharge, but not to an inpatient facility. You have a long list of possible responses for this question. They range from very rarely or never, less than once a week, 1 to 3 times a week, daily, more often than daily, or they have an ostomy. They do give you the unknown option, but not for follow-up and discharge. By then, they expect you to have an answer. How are you going to go about this? We've mentioned, lightheartedly, that health assessment interview. But you do need to address bowel elimination patterns when you're taking a health history. When you're having your patient take you on that OASIS walk around the house, make sure you get them in the bathroom. How else are you going to ask them how they would get on and off the toilet? And that gives you the opportunity to look around the bathroom. Look for cleanliness. It's going to tell you whether or not they're having accidents or incontinence. Look for the visible evidence of soiled clothing. Ask them outright, Do they have difficulty controlling their bowel? Do they have problems with soiling, uncontrollable diarrhea? If there's an aid present, private aid, aid from your agency, ask the aid, preferably privately, so as not to embarrass the patient, about what evidence have they seen of bowel incontinence, because this can then be addressed with the patient carefully to improve your plan of care and to give you the data you need to answer the question. So we've talked about these covariates. The quality measure for pressure ulcers, new or worsened, has 4 covariates. That's what we've talked about so far, is 3 of the 4. 1028, the active diagnoses. 1060, height and weight. 1620, the bowel incontinence frequency. And shortly, Ann's going to come up and talk about GG, lying to sitting on the side of the bed. 1028 and 1060, that we've already discussed, and GG, which is coming after the break, are new to the OASIS-C2. They will require some teaching and reinforcement with your staff. There are no changes to 1620, but the importance of it is what we want you to take away from this morning. We want you to think about how that impacts pressure ulcers and how you're going to educate your staff so that they will ask these questions appropriately. Earlier this morning, Ann talked about developing action plans. We need you to go back and look at your policies and your procedures. Policies are the rules for what your nurses are and are not allowed to do. Procedures are how they go about doing it. Make sure you have validated resources for the how-to. Develop an education plan. Please use the scenarios in this presentation. The versions that will be posted will have the answers that you can then pull out, use this as a testing or a competency for your clinical staff. Consider what process you're going to use for your OASIS review to make sure that the data they're collecting is accurate and reflected appropriately in the forms. We've given you some resources here that you can use to get additional information. They're all hyperlinked so that when you have this presentation back in your office, you can click on these active links and they will take you to these different sites. Okay, questions. Am I going to get off easy? Nobody's got questions about height and weight, right? Everybody's cool with that one, yes? Am I really going to be that lucky? Usually I'm bombarded with the weight one. No? Well, I've either put you sound asleep. There we go.
I do have a question. So if the patient is hospitalized on day 20, this is about the weight.
Yep.
And 3 days later, home health resumes. So what weight do you use if the patient is unable to stand because of shortness of breath and the patient has CHF? Do you just leave it blank or you put a dash?
You're going to, if you already had the patient and you obtained a weight on start of care, then you're going to use that weight if it's within the 30-day window.
Even with CHF?
Because you would need to be monitoring the CHF from other parameters as well. You're going to have lower extremity edema. You'll have ascites. If they're an amputee, you might be using upper arm circumference and abdominal girth to measure the congestive failure. Because you're always going to have multiple parameters. Weight is the most reliable, we know that. But if you can't do it, you can't do it. Patient safety always has to come first. Okay? No, in the scenario, it says you use the weight you obtained on start of care. If you could not weigh the patient on start of care, and they went to the hospital and came home and you did a resumption inside the 30-day window and you still cannot weigh them, then you're going to leave it blank because you can't. You use the dash if the patient was transferred back to the hospital or died. Okay, but you can't use the information from the hospital. They have access to a seat scale or to a bed scale. I know some of the larger agencies, especially if they have a cardiac rehab program, have invested in a seat scale. Now, those can be pricey, but it is certainly an option. Yes. Can you come up to the mic for me, please?
It's about the weight. If a patient is discharged and then readmitted in the 30-day window, can we still use the weight from the previous episode of care?
So that last weight falls within a 30-day window. That's a question I've not been asked before, and if you don't mind, I'm going to hold and consult with CMS, and then I will get back to you after lunch. Yes, can you come up to the mic?
What if our patient is diagnosed only with pre-diabetes? How would we answer 1028?
I'm sorry, you'll have to repeat that.
If our patient is only diagnosed with pre-diabetes, how would we answer 1028?
I'm sorry. Come up closer. I can't. It's me. It's not you. It's me. Oh, they're pre-diabetic. Okay. Is there, if you're going to have to look for a diagnosis, an actual written diagnosis, pre-diabetic would tend to be a term that someone might use, but you're going to have to get a hold of the physician or his or her designee and get an exact answer. They are either going to be treating them as a diabetic or they're not. Most likely, if they've actually written pre-diabetic, they're going to consider diabetes an active diagnosis and commit to that on an interim order so that you can then use it. But you're going to need to get them to commit one way or the other. That helps you to code correctly as well. Okay, anyone else?
I have a quick question.
Yes, ma'am.
We've encountered patients when we get to Mood 1028 about the active diagnoses that they say they have in their record that they are diabetic from the hospital, from the physician's office, and they say, well, I am not a diabetic. They don't have medications. They don't check their blood sugar. What we have done is we contact the physician's office and ask them to confirm, and then we have them write and sign an order.
Exactly. Okay. Because then the physician is confirming it, and that gives you the presence of the diagnosis, but then you're going to need to look at what the clinician and the physician want in the plan of care before you can determine if it's active. Anyone else?
Good
Yes.
morning. Can you tell me the citation for the 30-day window information so that I can cite it when I talk with my staff?
I know, isn't it? It makes it so much easier when you can wave that citation under their nose.
Yes, it does.
Okay. What I will need to do is to look that up. I don't have it here, and I prefer to be able to give you the exact information. So we will add that to the Q&A list, and we will get back to you with that. And someone up here had a question also. I did see a hand. Yes, ma'am. That's up to you. You'll need to decide what your policy is going to be and what your procedure is going to be. Given that you can purchase a significant number of them at, the $8 to $10 range in your local Target, it really is not a huge issue. You need to have a policy. I can't tell you what your policy should be, but you do need to decide with the support of your professional advisory committee what you believe your policy should be and then act accordingly.
Right here.
Yes, ma'am.
So I just want to be clear. Are we allowed to ask the patient for their weight? Because in the OASIS, it has actual and stated. Are we not allowed to use the stated weight from the patient?
No, the weight has to be collected.
So can we take it off the OASIS then? Because if it's there, not everyone was in this training, and they might think it's okay to put a stated weight from the patient.
No, the way the question is worded, right on the screen, you have to obtain the actual weight.
Okay.
If you could accept a stated weight, then you'd be able to accept the weight from the emergency room from before the on the referral. And we're not allowed to do that. You have to actually obtain the weight.
Okay, so is there any circumstance, because it's there on the OASIS, is there any circumstance under which they can mark that? Because if there's no circumstance, why is it there? I just want to know.
We will get you this citation.
Okay, thank you.
Anyone else? Yes, ma'am. See, I knew this weight question would do it.
I just wondered if you could give us some of those resources you mentioned that are that would give us some validated citations. You mentioned the VNA, I didn't get all of them.
There are a variety of different procedure manuals out there, textbooks. It's not appropriate for me to make a recommendation of any particular one. That would be considered an endorsement, and I'm not permitted. But you certainly should do the research. Look at different accrediting bodies, look at universities. Those are, where you're going to find the different validated resources. Look at who's vouching for them. And then I would definitely run it by your physician on your professional advisory committee so that you have something to back it up.
All right, thank you.
You're welcome. Okay, we have about 2 minutes left before coffee time. And I know not to get between people and the coffee. So, any other questions? No. Okay, I will be here the rest of the day, and unfortunately, you're stuck with me again this afternoon. So have your coffee, and we'll see you back here in 15 minutes. Thank you.